This is a 61-year-old female who is a patient of SLE, systemic lupus erythematosus, and she also had a past history of acute myeloid leukemia. She received bone marrow transplantation before. So this is a pleura effusion specimen. So for the patient with autoimmune disease such as SLE, sometimes they will develop pruritus and with severe inflammation and as well as pleura effusion. So in this pleura effusion specimen, usually we will look for the cell that we call LE cells. However, for this specific patient, instead of the LE cell, we do see some very tight three-dimensional cluster of atypical cells with enlarged nucleus, increased NC ratio, and hyperchromasia. So this very tight three-dimensional cluster looks like the patient had metastatic non-small cell carcinoma. The tumor cell is not so many. There were just only a few scattered cluster. But I think the cells are still diagnostic. So the problem is what type of cancer the patient has. The most common one would be adenocarcinoma of the lung. But I think we all agree that the morphology is a little bit different from the usual lung adenocarcinoma that we see. So the cells are also present in the cell block preparation. So you can see these tiny cluster of atypical cells. So in the cell block, it's more the nucleoli are more apparent, and it is still highly atypical. So we will check for the IHC. So we will do MOC31 to confirm this is a glandular epithelial differentiation, and we will also do TTF1. The patient had a remote history, possibly like 20 years ago, that she had ovarian mucinous adenocarcinoma, and she already had a surgery, and there is no disease recurrence for 20 years, but we'll still do a POC to confirm if this is not coming from the gynecologic tract. So sometimes these type of autoimmune patient, because of the low immune status, it's quite easy to develop some cancer such as leukemia. So the patient already had leukemia. So the next specimen is coming from a 79-year-old female. This is a ascites specimen. So on low power, we can appreciate there were a lot of like a tight cluster, hyperchromatic nucleus, and with highly atypical nuclear morphology. So the patient had a past history of serous carcinoma. So this is compatible with the recurrence of the disease. The cell block preparation also shows scattered tumor cell with much more abundant clear cytoplasm. However, the patient does not have clear cell carcinoma. She had serous carcinoma. So these clear cell change could be due to prior treatment. So the next case is a pleura effusion specimen coming from a 53-year-old female. We had the past history of lung adenocarcinoma, uh, which is EGFR ARC ROS1 negative, so most of the marker were negative. So she received chemotherapy, and this is compatible with recurrence of the disease. So you can appreciate that the disease burden is really high. And if we take a look of these tumor cell, you can appreciate that the cells are very different from the SLE patient, right? So this is the more common lung adenocarcinoma that we see. Usually in tight cluster, the cell is usually big. More often we will see vesicular nucleus and prominent nucleoli. The cytoplasm can be abundant, sometimes with vacuolation. So this is very different. I think the SLE patient, the tumor cell has a more hyperchromatic and coarse hypochromatic nucleus with coarse chromatin. And these typical lung adenocarcinoma has vesicular chromatin with prominent nucleoli. So that's why we need to do some stem for the SLE patient, particularly that is a new patient. So the next specimen, 72-year-old male. We've seen this patient many times. So the first 3 times that we see for this patient, we make diagnosis of small cell lung cancer. And the 4th specimen, we make diagnosis of non-small cell lung cancer, adenocarcinoma. So we talk about this patient that he could be a mixed small and non-small cell carcinoma patient who is an elder male but who is also a non-smoker, never smoker. So that is more common. So in these pleural effusion specimen, we do see some atypical cells, but the morphology is quite difficult to appreciate. A little bit difficult to tell if these were small or non-small. In the cell blood preparation, however, it is more easy. So we see a lot of these crash aggregates. And so we see a lot of these tight aggregates with a lot of crushing artifact. So here is a more classic example of a small cell carcinoma. So you see high NC ratio, and the chromatin pattern is kind of very like a smudge or misty, and you see this molding pattern. So this is unequivocally, this is small cell carcinoma. So again, we see small cell again. So it keeps changing histotype, which is kind of difficult to make diagnosis. I think these may also be a small cell carcinoma due to high NC ratio and these like a salt and pepper type of chromatin pattern. We do not see the tight aggregates of non-small cell cancer that we see in the last specimen. So I think for these specimen, we only see very scant small cell carcinoma elements. So we would call, for these specimen, we would call it small cell carcinoma because we do not see like apparent non-small cell carcinoma. So a little bit difficult, it keeps changing histotype, but the clinician know what's happening for this patient, and because he's under treatment now, so it's possible that we have this situation. So for the next specimen, we kind of dealing with a very similar situation. This is a Pura efficient specimen coming from a 51-year-old male. So again, for the cytospin preparation, I think the preparation is not optimal. We have a lot of proteinaceous material. The cells are mostly within this material. It's like a clot or something like that. So we saw some tight aggregates of cells, but the morphology is not very clear. If we only have the cytospin preparation, sometimes the cells show like a multinucleation, but multinucleation can represent mesothelial cell histiocytes, etc. It doesn't necessarily mean to be tumor. However, these very tight, like small cluster looks kind of suspicious. The cells are very, very small. So we go to the cell block preparation. We do see very similar cluster of cells. So if you pay attention to the size of the nucleus, if you see this is a reactive lymphocyte, it only show a little bit increase of the size, maybe 2 times as the lymphocytes. The chromatin pattern is kind of homogeneous and powdery, maybe a little bit salt and pepper. We see a little bit more cytoplasm and less like a molding pattern. So the patient actually had a past history of a typical carcinoid of lung. So the morphology is compatible with neuroendocrine tumor. So we see like in the row 2 different patient, one with a small cell carcinoma with Pura involvement, and this one with a typical carcinoid with effusion involvement. So the morphology is compatible with the past history of a typical carcinoid. So let's move to the fine needle aspiration. The first one is from thyroid. So on low power, we see some like a 3-dimensional cluster with these papillary formation. We see only very scant colloid in the background. Most of the cells are in very tight cluster. So if we go to this area, we do see there is like a cell ball with a very like a dark core. So this looks like a psammoma body in the center, surrounding by the tumor cells. And there is even more like a clear psammoma body. So you see this lamination of the central core. So this is a psammoma body surrounding by the tumor cell. And the tumor cell actually show prominent cystic chain. So you can see this vacuolated cytoplasm. So for the cystic chain, usually the nucleus will be less apparent to have this typical PTC pattern, okay? So usually for the cystic chain, the nucleus will be enlarged, will be rounded instead of be in oval shape. But we do see psammoma body, and we do see like papillary architecture. The cell does show some atypia. So in this more flat monolayer sheet, now you can appreciate more easily the typical classic PTC feature with elongated nucleus and ground glass powdering like a chromatin pattern. Okay, so this is a case of PTC with some cystic change. For the cystic change, it's not uncommon that we will see these what we call atypical histiocytoid cells with these very prominent like a bubbly cytoplasm. And here we also see another psammoma body over here. So if this is the only cell that we see, usually we will be only able to give an indeterminate diagnosis, such as suspicious for PTC or AUS, depends on like the number of the cell and the quality of the TPR that we see. Since we already see unequivocal PTC cells, these specimens can be called directly as positive for PTC. So we had a couple pap smear. The first one is from a 60-year-old female who present with postmenopausal bleeding. So for this specimen, we do see some atrophic background because we don't see like individual intermediate cell. Instead, we do see larger fragments of these tight cohesive intermediate cells. So the background show atrophy. So in this specimen, on the periphery of the specimen, we do see these highly atypical cells with vesicular chromatin, very prominent nucleolus, and with this glandular arrangement. So this is compatible with high-grade carcinoma. It doesn't look like squamous cell carcinoma. So the patient already had the concurrent curettage of the endometrium, and it does show a high-grade carcinoma. So this is compatible with the high-grade carcinoma from the endometrium. Okay, but the smear doesn't show typical what we call endometrial debris. We didn't see these like a granular like debris with a lot of PNN and histiocyte. We didn't see that. So this is more common in endometrial cancer, non-endometrioid type. So sometimes you will see these very high grade, particularly for high grade serous carcinoma arising from the endometrial cavity. So we didn't see these typical endometrial debris like background. Okay, but for this case, we can still call this carcinoma and high grade, and this is compatible with the cancer arising from the endometrial cavity. So the next specimen is coming from a 53-year-old female. So for this specimen, just on low power, you already see the background is not normal. We see a lot of old blood with dirty background and with some aggregates of hyperchromatic cells. So in the background, we see a lot of these very hyperchromatic cells. Some appear to be a little bit degenerated, but you start to see these like a spindly cells, and with a more preserved cell with higher NC ratio. And these typical cells are throughout the entire background, some in tight clusters, some in individual single cells. So this background is very, very typical for squamous cell carcinoma, okay? So here you see a little bit more mature squamous cell, and you see these very atypical spindle cells, some with a lot of degeneration in the background. For this case, we do not see apparent keratinization. So the tumor is less keratinized. It's more poorly differentiated. But because of hyperchromasia and the cell morphology with these spindle cell feature and the background show prominent hemorrhage, this is compatible with squamous cell carcinoma. So here you see like the spindle cell feature. The patient is from Yilan, and she visits the NYCU hospital in Yilan and was diagnosed with by biopsy with high CO with stromal invasion cannot be excluded, and she come to our hospital for further evaluation and management. So I think just by this smear, this is compatible with an invasive squamous cell carcinoma. Okay, so the cell morphology and the background appearance are very different from these two cases. One is a typical squamous cell carcinoma. The other is not so common. It's a high-grade endometrial cancer, but in the background, you didn't see any endometrial element. You only see these very, very high-grade tumor cells. So that's all the case for today.